Good afternoon, everyone. I'd like to call this meeting of the Health and Human Resources Subcommittee of Senate Finance and Appropriations to order. Everybody ready to be here? I'm not ready to be here. Y'all are? Oh, well, good for you all. Good for you all. We've got a lot of work to do, and as you're all aware, this subcommittee, particularly because of the volume of work we do, like to get started early. And so that's what we're doing this afternoon here. I do have some remarks. Senator Howe and I co-chair this committee, and she allows me to take the lead sometimes, so that's what I'm doing today. Okay. Well, good afternoon. While this meeting is in person, let me start by reminding the public that this meeting and all future meetings during this particular session will be live streamed, and for the reason that we're in with our health situation still, the public is strongly encouraged to view the meeting through live stream, because public seating, we're good here today, but as you know, as we get a couple controversial things on the table, the room will overflow. And one of the policies that will be strictly enforced this year is that, you know, however number of chairs are there, that's what we're going to be able to accommodate, rather than people being able to crowd into the room as we normally do. And so social distancing will still be in effect, and masks will be strongly encouraged. If not required. I think we're strongly encouraging right now. Is what we're doing. If you do plan to attend in person, as I indicated, there may not be an available seat. Also, the presentation will not be shown on the live stream, but you can view them on the subcommittee's website and follow along. We thank everyone for your patience as we work through this pandemic. As is typical for the subcommittee, we are beginning early. Our budget in this subcommittee represents about a third of the total funding of total expenditures for the state budget. And if all the members get the amendments that they're turning in, we'll probably be half of the state budget. So we'll see where that goes. So balancing the funding, as we always struggle, and obviously the stage has been set with additional revenues that are available to us this year, but we, members of this committee, are very much aware of pressures that have been there in the past that need to be addressed. Some of us don't think we have a huge surplus if we actually deal appropriately with some of the things that we've been putting off to take care of in this particular area. The subcommittee will likely have 5 or 6 meetings before we report the Senate budget out. And we'll start today with briefings to better understand the governor's budget in 2 larger HHR agencies. In future weeks, the subcommittee will receive briefings from other HHR agencies and on other important budget topics, including staff overview of the budget issues before the subcommittee, and consider any HHR-related bills referred to the subcommittee. The governor's proposed budget, as you all would be aware, includes significant investments in health and human resources. These investments include Medicaid provider rates, community behavioral health services, and funding to stabilize the state's psychiatric hospitals. The subcommittee today will learn more about these investments from presentations by Department of Medical Assistance Services and Department of Behavioral Health and Developmental Services. After those 2 presentations, the subcommittee will also hear invited testimony from 4 speakers regarding developmental disability waiver rates increase and budget issues impacting community service boards. So today we'll have Director Karen Kimsey from DMAS and Commissioner Allison Land joining us. We will note that with the transition to a new governor, the agency heads may change at the agencies, and so then we'll invite the new agency heads to a future subcommittee meeting. Before we begin, I'd like for all the members of the subcommittee to just briefly introduce themselves, starting down the end there. Jen?
Good afternoon, Senator Jennifer McClellan, currently representing the 9th District, which you're sitting in, so welcome.
Hi, Adam Eben from the 30th Senate District, which is parts of Alexandria, Arlington, and Fairfax County. I'm glad to be here.
My name is Creed Deeds. I currently represent the 25th District.
I am Janet Howell. I represent the 32nd Senate District, and that's parts of Arlington and parts of Fairfax counties. Appropriations Committee, and I'm glad to be with you all.
Okay, very good. And we have also with us our staff person who we can't get along without, Mike Tweedy. And Mike, thank you for all the work that you do between sessions and prior to this meeting to get it all lined up. So with that, if there are no further comments at this time, I will welcome Karen.
Good afternoon, Mr. Co-Chair, Madam Co-Chair, members of the committee. I am Karen, and I am, if it would be easier for you, I can take off my mask, or if you prefer keep it on, that's fine as well. I just want to make sure you can hear me clearly. Does this sound okay? All right, good. Just want to double check on that. Thank you so much for the opportunity to come and present to you all. It's always my honor to talk about my favorite topic, which is Medicaid. So always get a chance to talk with you is always a pleasure. So one of the few things I'm going to play here with your little, there we go. I've been asked to talk to you a little bit about our forecast and the governor's introduced budget, but I will just pause briefly, as we always do in the beginning, just as a reminder for who the program serves. You may not be aware right now, but we're pretty close to serving 1 in 4 Virginians. The lion's share of people are children still, but with childless adults coming up very close now, as you can see, with 800,000+ children and over 776,000 adults. But having looked at this population number, you see large numbers of people, but then when you look at our expenditures, even though we do serve a lot of children and adults, the individuals who need the most services and costs for us, of course, are our seniors, understandably, and individuals with disabilities who have long-term care needs. So that still remains for us, even though we have grown a little bit. As you can see here, wanted to explain this piece. We have been a critical safety net during the public health emergency. We have gained over 427,000 new members during COVID. Many of them went into Medicaid expansion, as you can see. Unbeknownst to some, however, we added a lot of children, and that has to do with the fact that their parents lost health coverage during COVID. So that's when I talk about, the Medicaid program serving as a critical safety net. These numbers tell a very strong tale about how the supports is. At one point, we were adding more than 5,000 new members a week. It has dropped down now to about 3,700. As you are aware, the public health emergency at the federal level requires us to keep individuals on Medicaid until the end of the PHE. At that point, we'll begin the unwinding process, and I'll explain a little bit more for you on that in coming slides. I was asked to talk a little bit about the forecast itself. And as you're aware, the COVID pandemic continues to generate historic levels of uncertainty in our healthcare system. We have this virus itself has complicated the ability for Medicaid members to access healthcare services, a pattern that we've also seen with a larger universe of consumers, commercial and private pay. Utilization of some of these services declined, though, as members delayed their treatment for health concerns and postponed medical procedures, while hospitals focused their resources on patients with COVID. As a result, in this fiscal year, 22, Medicaid identified a $653.7 million general fund surplus. The forecast anticipates overall growth in the Medicaid program of less than 4% between fiscal years 22 and 23, and less than 7% growth between 23 and 24. The increased general fund cost in the upcoming biennium is attributed to the end of the federal PHE. This means the federal government will stop paying the additional 6.2% for medical costs that it has been giving us since January. That has been a total of more than $1 billion of federal assistance that has come to us to benefit not only the Medicaid program, but to the Commonwealth in general, and has definitely been helped to buffer the COVID impact on our Commonwealth. This slide summarizes the Medicaid program's need and surplus for fiscal year 22 through 24. As noted in the previous slide, we have a $653.7 million general fund surplus that was in 22 and a need for a $821.2 million general fund over the course of the next biennium. The forecast anticipates some enrollment growth that will continue after the PHE ends and that the enhanced federal funding expires, which will generate higher costs to the state. The recent extension, however, of the public PHE into January of this year, and we do anticipate that it will be extended further given the recent COVID spike, has pushed forward some of the costs that will be tied to enrollment growth, so we continue to receive the enhanced dollars as long as the PHE is in effect. So it'll create additional savings and increase savings going on, but once the PHE ends, that's when the costs will start to build, and we do have that as much as we can taken into account. As you can imagine, as with all states, this is a shifting process for us depending on the PHE, and so we'll have to adjust the forecast or look at that as time moves on. So with the continued waves of COVID-19, we will continue to monitor closely the utilization of these services and do our best to support our providers who are continuing to provide very critical care during this time, especially to make it high-quality health care while people are trying to navigate the COVID experience. That's what I affectionately call it. Do anybody have any questions about the last two slides before I move on to the expansion growth discussion? Okay. So you may have seen this slide before, but this is a really fascinating look at how the Medicaid program serves as a source of support during recessions and economic growth. So this is our growth over the last 33 years. And as you can see, our growth increases during each recession, and those are the little blocks that you see, I think cream colored, I would say, on this side. But unlike the prior periods, this is our first pandemic ever in the history of Medicaid in Virginia, which started in July of '69. And we're entering our third year for COVID, so that's why you see the numbers continue to drive, because as I reminded you earlier, we cannot remove anybody from the rolls until the PHE ends. So, but when that does happen, we have 12 months to take a look at that and then help people unwind from the program. That means we have to determine their eligibility. And while we do that, if they look like they do not meet criteria for Medicaid, then we will help them and get them navigated and help them to, steer them towards other types of insurance options, like in the marketplace, et cetera. So hopefully we will be able to help with that. Now, the Build Better Back legislation might affect this in some way when it passes, because it will be more directive in helping us, telling us to help people find health coverage before they're removed from Medicaid. So you might see some changes or adjustments. My team's been hard at work. We started developing an unwinding plan right when it started. So we have a plan in place. Please rest assured, a really stellar team at the agency keeping an eye on this and working nationally. So we will have adjustments for it and be able to share that with you as the time comes close. But we do anticipate at this time it will take at least 10 months to successfully unwind, because we have to do systems changes. Our goal is to try and navigate and process as many people as we can through systems changes, like if people age out, like they turn 19 or they turn 21, or even some people age into Medicare. So those types of pieces we'll be able to do with some quick systems changes. But the ones that are going to be more challenging, the ones that have to have a manual determination, the locals, even though they're working very hard, they'll get overwhelmed with that sheer number, so we'll have to hire a team at the state level to help do that processing. Okay, so now I'm going to talk to you a little bit about our budget, the governor's introduced budget, and what we're looking at in terms of 3 different groups for you: services and supports, our rate increases, Mr. Co-Chair, that you mentioned, and technical items for us. We are very excited to see that we have 1,200 new slots being appropriated, 600 for each fiscal year, and I'm sure Commissioner Land will go into more detail about that, so I will hold that for her, but we're very excited to see that. Also, covering preventative services and vaccines. This is for the, I would call the regular Medicaid population. Adults in the expansion benefit already have these services available to them, so this addresses an inequity in our program. So we're very thankful for that. Also, for the next piece, with the remaining Medicaid and famous co-pays, this was a requirement for us during the public health emergency at the federal level. They also noted to us this inequity as well, because expansion members do not have co-pays, and so this also addresses that inequity as well to eliminate those co-pay requirements. Another piece that you will likely have seen before, but it had been unallotted, was this is based off the Ohio model to help individuals who have addiction needs once they're leaving prison, that they've been paroled and they're leaving. We can actually use this funding, will help provide them with care coordination and support to get them connected to the medical services and supports they need, get that importantly, that prescription, connections to therapists before they leave, because this population is a population that has the highest rate of overdose and death once they leave. So this is a really important piece. This is general fund dollars, but we're hopeful to see, as you can see, to pull also NGF, pull federal funds for this very important initiative.
Mr. Co-Chair,
Yes.
can I just about
Senator Evans?
release that slide?
Go right ahead.
On 1,200 new developmental disability waiver slots.
Yes.
How big is the waiting list now?
Mr. Co-Chair, Senator Evans, I believe it is 5,700 on the wait. For the, I was thinking about the urgent,
780.
for the priority waiting list,
Priority one, that's all. Priority one is like 3,500.
3,500.
I
Yes.
see.
Okay. Thank you.
Thank you. Okay, and we also wish to thank you for the dental benefit that went into effect. Significant utilization already underway. However, the rates are still low, as we've seen, and also you may have seen in some articles published recently about this. This proposes to increase the rates up to 5%. But I'm sure you will likely hear from stakeholders a desire to see that increase go higher. But this is in place and set up there for them, at least a 5% increase, unless you all would like to drive it up a little higher. And I believe the staff have the estimates for that in case you want to contemplate that. Also, you can see here proposed increases in rates for primary care services, up to 80% of the Medicare equivalent. You have done increases in the past to help bring it up, but it's to the Medicaid benefit. This addresses it to Medicare rates. Also, the rates for DD waiver services. So one of the things is you'll see this does increase the rates for all these services. In particular, one identified I wish to acknowledge is skilled nursing. It does across all programs, not just DD. So in case there's a question or concern about that, it does address CCC Plus as well as the state plan benefit. So there was some confusion about that, and we've been helping stakeholders to understand that. But for this, we're actually looking at bringing the services up based on the recent rebase done by the Department of Behavioral Health and Developmental Services. Some services were selected by the administration in lieu of like all of them with one general across-the-board increase. Certain services were targeted as we are still exiting out of the settlement agreement, and it was believed these were the services that would best address that need. But you also will also have the complete piece. We'll be walking through it with Mike about how we came up with the methodology, what types of increases, and if you all should desire to touch other services, you'll have that available as well. And I'm sure Commissioner Land can help answer additional questions related to that as well. But it's been a true partnership for us in working on this and working with our DD community and system, and are very grateful to the stakeholders for this. As you can see here, there's more detail about the rate increases as well as the percentages for that went up for your just for your convenience to have. The item on the left. So I do wish to mention here that the Medicaid enrollment has increased significantly during the pandemic, and providers are still struggling in some levels related to the pandemic, although they have a lot more people to serve, at this time. So we have prioritized assuring that the provider community can continue to offer services in the community-based services space, because they are also having, as you know, significant transition workforce problems in hiring people, and so these increases are desperately needed to keep that up. So the rates on the left-hand side are proposed in the governor's introduced budget right here to assist the providers in the system, and it's off of, you may have heard it called before, the Burns study. So this is the updated rebase numbers. The table on the right-hand side, though, also shows HCBS providers that received that 12.5% temporary increase that you all authorized for us through ARPA dollars. Now, these temporary funds.
Mr. Chair, could I?
Yes, Senator Deeds?
Yes, sir.
Ms. Kimsey, are those, there's a 61.6% increase for supported living residential and 71.4% for nursing. Those are not misprints?
No, sir, those are not misprints. But if I may speak, for example, to private duty and skilled and congregate, this has been a service that we've been, as a system and nationally, struggling with because of nurses and needing the higher rates. And so this particular service has been a very significant focus of the settlement agreement with the attorneys in DOJ. And so in order to bring the rates up, these are rates based off of, they look at what's done, commercially and in business, what it actually costs to provide that service. And it was, once they did the rebase, it looked at that, and it really did need to bring it up 71% to make it a competitive rate, especially during this time.
Okay. Senator Evan?
Is there any differentials in Northern Virginia for any of these? I know that like the group homes
Yes.
incur higher expenses and stuff. There's some other costs that are there. Do any of these include a higher rate for certain parts of the state, or is it the same everywhere?
Yeah, Madam Co-Chair, Senator Eben, I wish to, yes, it does take into account the differential. So you may not see it here in the percentages, but the differentials still remain for that. These are just aggregated percentages. You're welcome.
Karen, clarification on your chart there. The ARPA 12.5% increase will phase out. The increases, they're based on the original base rates rather than the amount with the ARPA increase?
Yes, I do believe that is correct. So I will answer, Mr. Co-Chair, this, I was going to just say these are temporary on the right until December of 2023 of this year. July. I'm sorry, I thought you told me the last number. All right, it's July of this year. So we were just trying to get them through of this
Okay.
year. And then, but that's why it's on the right, and you see that column on the right separate from the left. But you're right, the rebase is based on the current, the rates as they currently are without the 12.5.
Okay.
Now, the only exception to that is personal care and respite, because we need that for the minimum wage increase. And so that is a permanent 12.5% that stays in. So you'll see, for example, in the subsequent year, the 1.6%, the second year of the biennium, that's because it's adjusted for the minimum wage, and so it only needed to increase by that much more.
Okay.
We also are seeing increases for our OB/GYN physicians, which is very helpful because that's been one of our big pushes with this current administration, maternal child health initiatives. And while we are expanding and looking at home visiting and creating doula benefits, our OB/GYNs needed a little help on their rates, had not been increased in quite some time as well. And so that's why you see this increase in here. Also, we were being more mindful and looking at rate increases for services. We actually took a look at which services had not seen any significant rate increases in a long time. OB/GYN was at the bottom of the list, along with vision. And so that's why you see it here, particularly the rates for our children. And of note, it's really, as you know, some even children, if they cannot see and they're in school, they start behaving out, and people assume it might be a behavioral problem when all they need is glasses. I have to say, I speak from personal experience. A distant relative of mine, that actually happened to their child. They did not know that the child needed glasses and were held back a year. So vision is critical. It's really important. That's why you see these rates going up. There may even be some discussion to look at different types of modalities for how the health plans can reach our kiddos. So this is good news. The third one is actually about with our residential treatment centers. We call them PRTFs as well. This year, we set it doing a cost-based methodology, cost-based reporting for them to be able to get paid for their true costs. This allows them to be rebased every 3 years and also provides an annual inflation adjustment for your consideration. There's also heightened interest in funding human milk banks, especially if they're donations. It is growing. There are several states who offer this, I think 10. Around the country with growing interest in this. So this is language to ask us to take a look at that. Also, on behalf of the Department of Behavioral Health and Developmental Services, we have, yes, sir.
Actually, we have done a study of the human
Actually, we've just done a study through the Health Insurance Reform Commission on that particular issue. So we may not need to duplicate the same study that we just did this year with the Health Insurance Reform Commission. And you know, there is a facility in Norfolk that does participate and sort of operates that for the right now. Is the only one in the state doing that comprehensively.
Mr. Chairman.
Sarah,
We may be talking about the same thing, George, but 2 or 3 years ago, I put in a bill to make it a mandated benefit, and it got sent to what I thought was called the Mandated Benefits Commission, but maybe it's changed.
Well,
But
the name
it
has
came
changed.
out.
It's Health Reform.
Okay, so it is, so yeah, it got out.
Well, it got studied this year. It did
Yeah.
not get. It's not
But-
been resolved because there are other issues as to who pays for it. So.
Mr. Co-Chair, Madam Co-Chair, and Senator Barker, thank you. We'll take a look at that and see if it, I don't think our team was aware if they had asked us related to the Medicaid costs, but we're happy to take a look at that study for you. That would be great. Okay. So the next one that we were looking at here is, as I mentioned earlier, it's funding through the Department of Behavioral Health and Developmental Services to provide increased costs to increase our salaries for the direct care staff in the centers, as you can see here, to try and help maintain competitiveness for the staff there to hire qualified folks into second years. Also, in adjusting the healthcare fund appropriation, this just modifies that to reflect the latest revenue estimates, and tobacco taxes are projected to increase by $9.6 million over the biennium based on Department of Taxation's revised forecast. However, the revenue from the Master Settlement Agreement and Medicaid recoveries are expected to remain unchanged. Since the fund is used as state match for Medicaid, any change in revenue to the fund impacts general fund support for Medicaid. So you'll see that adjustment made right here. Also, you'll see here, to allow blending of third-party liability rates, this gives us the authority as an agency to create what's called a blended rate model to merge the capitation rates for those who have third-party liability or third-party insurance compared to those who do not. So as we merge the program into managed care, we have what we call third-party liability, or a TPL program. And so as we made those mergers and changes, we realized we needed an adjusted capitation payment to offset and reflect that people have other insurance costs, and we're not necessarily paying a health plan for an individual total amount and not taking into account that. So this helps us to do that. Very important. Also, we just appreciate so much the funding that you provided us this past year for contractor support as we pursue our Project Cardinal initiative, which is merging the two managed care programs, Medallion 4 and CCC Plus, into one program. I'm pleased to report that we're on target with the work that we're doing with that. We actually have a draft consolidated contract that will go into effect July 1, and it's currently under review with stakeholders as we speak. So that we are seeking additional dollars just to continue moving and to make sure that we finalize all those changes in the merger of that, and having the support of our contractor at this point is Manat Health, which is nationally recognized. They helped us with Medicaid expansion and development at one point of the work requirements, which is an excellent product that they had done for us, as well as others. So it's been very helpful, and I'm very thankful for the extra support in that manner. Also, you'll see the language about clarifying continuous eligibility for pregnant women. You gave us that gave us the authority to move in to do that. Ask the federal government for permission. We do have federal authority to extend postpartum coverage for women who've had babies from 60 days to a year. This language just clarifies the state authority for us to do that. Also, there's language requires us to take a look at reviewing emergency room utilization program, just to make sure that its impact on member care or experience regarding the reduction of that has not had a negative impact. Also, you'll see this is another critical piece. It's resulting from the public health emergency. So if an individual is receiving long-term care services and they have a change in circumstance, they are they've had a COLA increase from Medicare, or their patient pay cannot be increased. So if we see that adjustment come through, like they may get more resources for their Social Security check, they cannot apply it, and we cannot adjust it because we're not allowed to right now. And so as a result, people have started accruing excess resources. Now, all we're asking for at this point is to just have funding to set aside to keep them on the benefit until we can get to them, and they also have time to spend down. So these are individuals who are likely still eligible for Medicaid, but because of their resources, they could be removed from the program once the PHE ends. So this funding will help continue their eligibility until they're able to spend down. We anticipate it's about 200 individuals who have impacted. This also includes individuals who were institutionalized but moved into the community as well. So it's not just institutionalized individuals. This will help them. This line up here allows the Children's Hospital of King's Daughters to retain their state share of any federal disproportionate share or DISH payments for the period of June 2nd, 2017 through June 30th of 2020. The action is limited to refunds required under federal court decision that's in connection to the calculation of members of dual eligibility of third party. So this difference it just allows for Children's King Daughters to not have to pay that back. Also, we have a federally required, it's called interoperability requirements, to support the costs associated with getting managed care systems of care. You did that for us last year to help with that. It helps with a federal requirement we have. However, we neglected to include our administrative proportion for systems of care in the fee-for-service part. So this additional cost helps us with systems changes on the fee-for-service side. We are also seeking a position to support our provider reimbursement division because we've had increasing complexity with the nursing facility reimbursement, like with our value-based purchasing methodologies, and also rate methodology issues as we are going to switch from one methodology to another. So they're looking for somebody also to have actuarial experience here because we are moving more into managed care and we rely heavily on our actuaries, and it would be nice to have another person who has actuary experience at the department. Also, enhancing our financial oversight. We've worked so hard the last few years to be more open and transparent to our system about how the program is operating from a financial standpoint. We are seeking 5 additional positions that will continue to improve and enhance our oversight of the program itself to address the most critical needs in areas of budget, our fiscal areas, as well as provider reimbursement. Some of the other funding, these are more technical items in nature related to the program. We've had increases in costs related to, it's called the EQRO, that's our quality monitor for managed care systems. So you will see that it's for detail, it's just more enhanced monitoring and oversight costs. We also have removing the funding in the next one, associated language for one-time tasks that are required to be completed. Includes facilitated enrollment efforts as well as analysis of pregnancy and birth outcomes. So that's just all being removed because we had already accomplished that. You'll also see adjustments to reflect agency operations for a variety of things, such as sunsetting of financial assistance for a health research program that we no longer are going to need, and then transferring certain dollars and up to helping DBHDS facilities true up their general fund and other federal dollars. So you'll see that there. Also, just some funding for our systems that we use for IT, telecommunications, financials that are all tied to the state systems. This slide right here just shows the caboose. I had just already talked about these with eliminating the copays as well as and these are tied to the PHE. These are just go back in. So I already discussed those. This is just reflective for the caboose. But that concludes my presentation to you all on the forecast as well as the introduced budget. I'm happy to entertain any questions for you at this time.
Okay. Any members have additional questions?
I'd like to just make a comment.
Yes, indeed.
I've been here an awfully long time, and while I've been here, I've observed over and over when there are big system changes in state government, there tends to be serious hiccups. But you have overseen some amazing system changes, Medicaid expansion, your arts program, the managed care reform, the dental improvements, as well as the pandemic. And your job, you have done absolutely flawless. I have not heard of any hiccups whatsoever, so I really want to thank you.
Thank you. Thank you, Madam Co-Chair. It's been my honor.
Okay, good. Other comments?
Okay, thank you.
Very good, Karen. Thank you for your
Thank you.
presentation. Thank you for the good work that you've done over the past several years, and we'll see what the future holds here.
Yes, sir. Thank you.
Okay, thank you. All right. Allison? Good afternoon.
Hello. Thank you for having me here today. Okay, let's see if I can. I first wanted to share a slide that has our main priorities on it as a summary slide. And so you can see that our top priorities for these proposals are going to be addressing the high census and extreme staffing challenges at the state hospitals, addressing the critical infrastructure needs of STEP Virginia, the comprehensive crisis system, and the Marcus Alert as part of that broader, as well, behavioral health system, as you see there with the community behavioral health subline, and then also advancing our extensive IT needs and IT security investment needs, and then finally providing resources that are needed to fully exit the Department of Justice settlement agreement. And so, as you know, and as some of Karen's comments show, our mental health, substance use disorder, and developmental disability system is in the midst of expansive reform. So we'll see a lot of different proposals during the presentation that help that transformation. Wanted to take a few minutes and talk a little bit about ARPA and our state and local recovery dollars that we've received and will also continue, and were earmarked for FY23. So while all of the state hospitals that we temporarily closed last summer due to dangerously low staffing and dangerousness are now reopened, we're currently experiencing, just for your information, the highest COVID numbers that we've ever seen at our facilities. And that's actually continuing to force bed, unit, and at sometimes all full facility closure at this time. So right now, as of today, we have 425 positive cases, 306 staff, and 119 patients today. That causes many folks to be on the waiting list for our facilities. Many of those on the waiting list are COVID positive as well. So in addition to the 1,600 staff, direct care staff that we are down, we also have another 300 that are out on quarantine and isolation due to positive COVID status. So I say that because a lot of what we've been so thankful for has been to receive the funds, to be able to fund the PPE requirements and things that our facilities are needing because of the COVID status and the pandemic, but also for all of the dollars that we got to help with our staffing issues. So it's really been such a help in our mitigation efforts, and also providing those contract staff bonuses and dollars for our staffing crisis. And we need to continue those. So in FY22, the column, you can see the dollars that we received. And then also those dollars in that second column that were earmarked to continue in FY23. And then in the third column are those that are in the governor's budget.
Mr. Chair. A reporter called me this morning, Commissioner Land, and told me that 21 people at CCCA, 21 employees had tested positive, and we're down to 11 beds there. Is that correct?
Correct.
11 out of 48 beds.
Right. We had gotten back up to 18, but then with more staff having to go out on isolation, we had to reduce the number of beds because we can't manage the patients.
Is it, how, Mr. Chair, what sort of vaccination rate do you have among employees at CCCA?
Okay, I don't have that number in front of me, but overall we're around 82%, but we're still seeing people getting the virus that have been vaccinated, boosted, and have had the virus and have multiple times had it. So we have instituted crisis staffing standards, and so we are taking that new guidance of after 5 days of quarantine, and we do the test, and if they are either negative or not showing symptoms anymore, we are bringing them back. So we have moved to that instead of the 10-day. So we're doing everything we can to get the staff back in so we can open those beds. Yeah, yeah. So,
Thank you.
thank you, sir. We also had ARPA funds included for optimization and business process improvements, and those dollars are supporting integration and infrastructure efficiency with these critical one-time dollars. And then the governor's proposed budget helps us continue these important efforts to shore up staffing and ensure accountability for our multiple transformative initiatives. And so you'll also see that along with those that were earmarked during the special session and committed, you also see an additional $700,000 in ARPA dollars in FY 2023 for telehealth services to be improved at the state hospitals to help again with that access to providers since we have such a shortage. Let's see. Going to put some of these proposals into what I call buckets. So we're going to have some that address the bed census pressures but are more focused on community efforts, and then we'll see the ones that are more on our facility operations side. So these next two slides are the community efforts. So you can see that all of the pressures that we're having at the state hospitals do have a major ripple effect down to our other partners with like the CSBs, our law enforcement, the emergency departments at the private facilities. And law enforcement really have that emergency custody of people that are waiting for a temporary detention bed, and they can be held for up to hours and sometimes days at a private, our state hospital bed is trying to be located. So the governor did propose to expand a contract for alternative transportation. You'll see there the first item. And that's going to free up law enforcement from having to transport an individual from an emergency department to the temporary detention facility once the bed is located. And a lot of times that may be all the way across the state, particularly since we're working with a wait list, and it's the next person on the list to the next open bed, which may not be the closest bed, geographically. And then now that the alternative transportation services are statewide, that happened in April of this past year, we've seen a real increase in the need and the amount of services that are being delivered there. And so we're going to need, if we want to be able to continue operating at 24 hours a day, we will need to have those additional funds, because without it, we're going to be limited to 16 hours a day as the program continues to expand utilization. It also would expand.
If I could interrupt you just on that point there, obviously the planning is in place, but it's not anticipating implementation until fiscal year 2024. Are there some things that y'all are working on that we can do in the interim to alleviate the problem?
So you're talking about the one that's the transfer of custody, as opposed to I was talking originally about the alternative transportation, but we also have in the governor's proposed budget, you had put forward our patron a bill to do transfer of custody so that a contracted alternative transportation provider or alternative custody provider could be contracted to accept that transfer of custody and sit with the patient so that the law enforcement could go back on duty.
Right.
And there's going to need to be, it's a very complex code section, and there's going to need to be a language change in that. So the governor did not feel like that we would probably need that code first, and that's why he put the dollars in the 2024. I don't know if there's not. We've heard that there may be some other proposals that would allow it to maybe go forward and work on it this session so that we could get it for July 1st.
Mr.
And we
Chair,
would be happy to help.
We're going to have a proposal to discuss tomorrow at the meeting of the Behavioral Health Commission.
Good.
So we're happy to help in any way we can to get this to move forward. So, and then there was also a discharge transportation pilot that we did at Western State Hospital that worked very well, because we end up having folks who wait for days sometimes to get transportation when they're ready for discharge, just to get transported back to their community. And so that's not a reason to have a person in a bed locked in a state psychiatric facility when we have patients that need to come there. So that would be another opportunity to help with those pressures. The governor's budget also provided us additional tools to address the census pressures, like increased dollars for discharge assistance planning, or DAP funds, and it would also address recent work group recommendations to target hard-to-place individuals. We also want to continue a pilot for individuals in the state hospitals with dementia, a primary diagnosis of dementia, because we know that when patients are inappropriately admitted and held in state hospitals, it can be a big problem for our census, and they're really hard to place once they get that status of having been in a state psychiatric institution. The pilots that we have are working extremely well with community providers to help direct individuals with dementia at risk of institutionalization to more suitable care. And the proposal also, you'll see on there, would provide 6 regional dementia specialists to provide crisis and diversion services and increase community understanding and competence on appropriate care for older patients with dementia. And then that final one is budgets to increase staff to complete forensic evaluations. Many times our folks get stuck at the hospital waiting for an evaluation when that would be all that they would need. And so that would really help our forensic census in the hospital. So we're glad that one got put forward. So some of the facility items to address census pressures. The first would start a pilot program to expand discharge planning and therapeutic intervention services from 5 to 7 days at 2 hospitals, Central State Hospital and Southern Virginia Mental Health Institute. Ultimately, our hope is that all state hospitals would offer full services 7 days a week instead of just 5 days a week, which would free beds for admissions and better reflect their actual status as acute care hospitals, which should be offering full services 7 days a week. The budget proposal would also we have one to add security staff at Eastern State Hospital and Northern Virginia Mental Health. Both have high forensic populations and lots of aggressive behaviors. And then we would also ask for 3 behavioral health on-call administrators. These are positions that we currently have being done by senior level executives that have full-time jobs, but they're really on call 24/7 to help with consultation to the private facilities and making sure that exhaustive bed searches are done to help because of the waiting list issues. So this would ensure that those bed searches are exhaustive and that we're helping in any way we can in consultation with the privates to help them as they are managing that with those patients on the wait list. Also have several other proposals related to the facility. These are related, as we've talked about, to the staffing contracts that we implemented last summer during the staffing crisis, which we know will continue to be so important as the conditions at our hospitals remain very fragile. And so you'll see that we have some in the caboose to continue those staffing contracts. And then for those increased pharmacy costs that we're seeing just across the board, and it's being seen nationally, for our facilities. We do need to have some positions that can work to ensure that the eligibility, not just for Medicaid, but for any social programs, any of the eligibility is put in place for our folks as they're discharging from the hospital. A lot of times if they're not insured, it's hard to get those follow-up services scheduled, so you can't really do a discharge plan. You can't discharge a patient without a safe discharge plan. And so if they don't have their eligibility in place, then all of it comes through DAP funding, which can be very expensive, and sometimes we can't even get a provider to take the patient. So that will help greatly. And then the ongoing cost for expanded telehealth at the state facilities is on there. I'm sorry, it's a fire hose. We were very lucky to have so many things put forward, but I know it's a lot. So then also, As you know, COVID-19 was the last straw for many of our healthcare workers who realized they could make more money in a safer and less stressful environment. And our staffing levels declined and have continued to decline over the pandemic. We did institute the bonus structure using the ARPA dollars. That's been effective. But as a Band-Aid, it's been effective as a Band-Aid. But we realize there's no way to attract and retain workforce for long without salary increases, seeing those dollars really put into the salary increases. And just to remind you that the Mercer compensation study that we did last year showed us our rates for direct care staff were in the 10th percentile of market. And that means that some were making less than our new minimum wage of $11 an hour, and much less than the prevailing rate of $15 or more at many fast food, retail, and other businesses. In addition, our workers' compensation data shows DBHDS facilities are riskier than even DOC, and new salaries should be competitive and reflect that risk that our staff face every day, day in and day out with our patients. So the proposal would increase the direct care salaries at all of DBHDS's facilities to the 75th percentile of market rate and fund overtime cost at the mental health hospitals. And
Matt,
go ahead.
Senator Dees?
Mr. Chair. Ms. Ellison, it's not really been effective, though, in terms of recruiting people to CCCA.
Correct.
You've got 48 beds there. You've only got 11 staffed right now.
Right. Well, we would be at 18 if we hadn't had the COVID, but I know. But yes, sir, we have not seen it increase the recruitment, but we have seen it stop for the retention. It has stopped the bleeding of people
Okay.
leaving, and so.
But you've still got 30 beds to staff, even if you get back to 18. You got 30
Right.
beds,
Yes, sir.
and that's all we have for kids in the state.
Right. Well, state beds, yes. Yes, sir.
State beds.
Yes, sir. I think that if we can the problem is that they can go and work somewhere else that's not as dangerous and that gets a better pay. And so if we can get it into the actual rate, which this is what I always said, was I thought that the bonuses would help with the retention, but it's still hard to get somebody to come on and say, we're going to pay you $11 an hour, and then you can get a quarterly bonus if you stay, and they have to trust that we're actually going to deliver on the bonus. It's still very difficult for somebody to agree to do that. It's hard to be competitive with that kind of an offer. And so I think that once we can get it to the rates and actually say we're going to pay you $17 an hour or whatever, for whatever the position is, that will be a much better situation for us to attract staff. Yeah. Okay, I did finish that one. Okay. Now I'm going to move to some proposals for community services improvements. And STEP Virginia is as you know, the model to implement a specific set of quality community services consistently across all 40 of our community services boards. And the governor's budget completes implementation of STEP Virginia by funding the last 3 steps, which are, as you see there in the kind of orangey yellow, are psychiatric rehabilitation, care coordination, and case management services. We do understand that with workforce issues, that will be a heavy lift. It also provides critical local infrastructure and regional management services to make sure that we're being implemented effectively and able to manage and optimize it. That implementation, these local dollars would come in forms of grants, and CSBs would have the flexibility to use those dollars to aid STEP Virginia-related workforce. And this budget, the funds to implement these critical services will be complete if we do this for all of STEP Virginia, and Virginians will have the opportunity to have the robust set of services across all CSBs. The next budget area I want to mention is crisis services. As you all know, we are now in the middle of developing a stronger crisis system that supports youth and adults in their communities by ensuring they have someone to call, someone to respond, and a place to go. And so this comprehensive crisis system you'll see there includes regional dispatch and call centers, mobile crisis teams, and crisis receiving centers, and then Marcus Alert programs that are being built out on the local level to divert people in crisis from the criminal justice system and hospital emergency rooms to the appropriate services. And this proposal of the governor's helps advance goals from this program by funding elements of the new National Mental Health Hotline. Starting this summer, people experiencing a mental health emergency will be able to dial 988 instead of dialing 911. And the proposals also continues the critical crisis system transformation process, including the implementation of that 988 number, bringing the next 5 Marcus Alert localities online as required by legislation, and appropriates $20 million in ARPA funding to continue work on critical elements such as mobile crisis, our call centers, and crisis receiving centers.
Mr. Chairman?
Yes, Senator Evan?
Can I ask, which localities right now have the Marcus Alert system, and do you know
We
which
we
the
can
next
get,
five would
we
be?
can get that unless there's somebody here that can.
This might be-
5 that currently have it. Rappahannock, Rapidan, Prince William, Virginia Beach, Richmond Behavioral Health Authority, and Highlands Community Services.
And do we know what the next ones will be?
Not off the top of our head.
Okay.
We can definitely get it to you.
Okay. No, just curiosity.
It's been prescribed in code.
Oh, okay, we did that last
What
year.
it says, and then we can figure it out.
Thank you.
Okay. I also want to point out some other proposals that expand. So, for instance, expanding Virginia Mental Health Access Program, VMAP, to include training and consultation for providers of services for early intervention, youth psychiatric emergencies and emergency departments, and urgent care centers, and expands recovery support services provided by the Virginia Association of Recovery Residences, the VAR, and if you'll remember, they got the ARPA, the $10 million ARPA. The budget also helps build the workforce pipeline by contracting with the Virginia Healthcare Foundation to pay for the cost of supervision hours needed for licensure for social work and counseling, masters of social work and counseling, but also for the cost of certification of licensed social workers and counselors who want to be able to become eligible to provide those supervision services. So that'll be very good. I'm just going to breeze through these. These are just some kind of other important areas. Workforce training and innovation programs to support emergency needs from the pandemic and transition age youth and specialized population. A media campaign and educational efforts to prevent underage cannabis use. And working with ABC to increase retail tobacco outlet compliance checks, all that are required for us to maintain our federal funding.
Mr. Chairman?
Yes, Senator Evan?
This may be an aside to talk about later, but earlier today, the Cannabis Oversight Committee had recommended beginning sales January 1st a year from now. And I'd be curious to know if you need more money for the underage cannabis marijuana public health campaigns. If someone could
So
follow up with me, perhaps.
we can follow up and let you know.
Before Friday.
Okay, sure.
Thank you.
Mira? There are some proposals around housing that I wanted to share. The governor's budget also recognizes adequate housing as one of the most important elements for people's security and stability on their path to recovery. The budget for permanent supportive housing would serve about 1,250 additional adults with serious mental illness who are leaving state psychiatric hospitals or who are homeless and at risk of hospitalization. There would also be rental subsidies and support services for 75 additional pregnant and parenting women, and funds for the oversight and management of permanent supportive housing programs. And then finally, the budget would increase rental subsidies for an additional 75 individuals with developmental disabilities per year. The next item is unusual in nature, but striking in its potential to take Virginia's behavioral system to the next level. First, the budget would fund a study to examine our current system of care. Studies have been done in the past, but with Medicaid expansion, managed care implementation, the increase in the behavioral health needs from the pandemic, our system's needs should be reevaluated and recommendations made for systems issues, not just services. Perhaps that would reinvigorate workforce development, financial realignment, and look at mental health rate adequacy or other system barriers that prevent us from doing more for people with mental illness and their families. Then the budget guarantees $100 million to implement these recommendations. The funds would be held in central appropriations, not in the DBHDS budget, in recognition that these recommendations to improve mental health very well may lie at the intersection of multiple agencies like DMAS, Department of Corrections, Virginia Department of Health, Department of Education, and others. For example, depending on the recommendations, funds may be used for rates, for workforce, or for other problem areas that require tremendous lifts to solve. Next, I wanted to talk a little bit about Department of Justice Settlement Agreement. These budget items will help us come into compliance and potentially exit the agreement. We have gained compliance with several sections of the agreement, and the deadline for compliance with the remaining sections has been extended by the federal judge because of COVID-19 to as late as December of 2023. The agreement has 121 provisions, and we have gained compliance, sustained compliance with over 80 of them. The remaining 40 are in areas such as quality and risk management and integrated settings. We are challenged by how to develop quality assurance and risk management systems that develop a culture of continuous quality improvement, but also complement our licensing regulations. The budget would add 15 licensing staff to help meet this requirement and address our ability to monitor the growing list of over 1,400 providers statewide. The budget would also add positions to manage the waiver management system and to support the mortality review process. The governor's budget also moves forward services for individuals involved in the criminal justice system, and these two include continuing an existing contract with the Department of Corrections for the supervision and monitoring of the sexually violent predators who have a court-approved conditional release, and it also includes expanding mental health dockets to make more services available to more eligible individuals on those dockets. We are currently in the home stretch of exiting the DOJ settlement agreement, but a significant hurdle remains to be cleared, one that I think is the one that is the hardest for us to deal with, and that's the validity and reliability and quality of our data is under constant scrutiny and is not being accepted in many times to show compliance. So we can assert compliance with our data, but they say the data is not valid or reliable, so they will not accept our data. And so this is a direct result of dependency on out-of-date technology and collected data from systems that were never designed for what they're currently asked to provide. Critical information is reported through Excel spreadsheets and access databases populated by hand entry, sometimes copied and pasted and then analyzed. Much of the data is contained in CSB and provider IT systems, but the various systems cannot currently share information. The governor's budget helps support data analytics for DOJ, STEP Virginia, quality improvement, and other critical programs. The work improving these IT systems and continuously improving the electronic health record can improve patient outcomes and reduce demands on facilities through more efficient patient management. The budget also replaces the DBHDS facility billing system. The upgraded system will interface with the electronic health record and will manage items such as patient registration, eligibility verification, operational reporting, and will result in improved revenue generation for the facilities. One-time costs for the purchase of the system are funded with existing agency balances that are earmarked for the implementation of the EHR. The Commonwealth is currently investing millions of dollars to improve and expand DD and behavioral health programs in the community, and a major improvement in IT infrastructure is needed to effectively manage these programs and adequately determine their value and return on investment. And so, Mr. Co-Chair, since Madam Chair is not available, that concludes my presentation for today.
A lot of information, Allison.
I know,
There's a lot
I
going on.
typically fire hose you guys.
Any additional questions for Commissioner Land, Allison?
It's a lot. It's a
Okay.
lot. So,
Yeah, you've overwhelmed us with information here. Yeah.
Thank you,
Well,
sir.
thank you. Look forward to continuing to work with you as we move forward with all of these moving parts.
Thank you. Appreciate your time.
Thank you. Okay. Those were our two major agency presentations. Now we have I think, four individual stakeholder testimonies, beginning with the Arc of Virginia. Tanya, we'll get you up here first.
Very good. Hi.
Hey,
Thank
how are you
you.
doing?
Good. How are y'all? First, Tanya Milling, Executive Director at the Arc of Virginia, and thank you for allowing me to speak today. You are all very familiar with the issues here, so I'm going to try to give you the personal perspectives of our members. So first, I want to say thank you for the continued commitment for funding DD waivers. Since 2016, when the DD system was redesigned, Virginia has clawed its way back from being 49th in the nation for supporting people with disabilities to now 38th. 38th, still in the bottom quartile of states for the provision of services for citizens with developmental disabilities, despite having one of the highest per capita incomes of any state in the nation. So without adequate funding, our system is broken and ineffective in many ways. The waiting lists, the number of people just that in need continues to rise, while the community capacity continues to drop. The workforce crisis, like all industries, the community of care is facing a devastating workforce crisis. But unlike all industries, Virginia's DD system was in a workforce crisis long before the pandemic due to low provider rates that were outdated and designed to pay staff at only the 50th percentile wage, making it impossible for the DD system of care to keep up with the labor market. The approach: our system is simply reactive, only providing services once someone's needs become urgent. The only way to get a waiver in this state is to be in Priority 1. That builds a cycle of dysfunction, never allowing the system to balance or to benefit from utilizing less expensive services. It's like people are being triaged in an emergency room that is full and overflowing, instead of building a system that's proactive and efficient and long-visioned. The impact: this all leaves people with disabilities and families without services they desperately need. Right now, 0 of the slots allocated in fiscal year 22 have been given out to people, and 1 in 4 of the fiscal year 21 slots continue to go unused because of the lack of community capacity. So if 14,000 people are waiting, if those with a waiver slot can't get staff or help, and if over 1,000 slots funded by the General Assembly go unused, then we would say the DD system needs to be rescued. The Arc of Virginia, as I'm sure you know, is a primary source of resource navigation for families. We get calls from across the state all the time to get assistance in navigation through the system. And this last year, through the pandemic, but particularly this last year when the workforce crisis has hit such a head, the requests for assistance have grown significantly and become much more dire. We've received countless calls from individuals and families in desperate situations, and these are just some of the recent examples: being institutionalized due to a lack of critical services, laying in bed for 2 days, unable to get up, obtain food, medicine, or go to the bathroom, going days without a shower because no staff showed up, being displaced or relocated without notice from your home because of staff shortages. A group home in Western Virginia, struggling from a lack of staff, had to close and drop off all their residents at a local hospital emergency room. We are also seeing higher instances of harm, like a broken shoulder bone that staff were unaware of, bruising all over someone's body, oozing fluid from their ear without explanation, someone found soiled when their family came to pick them up for a visit because staff had just been too busy to help them. These are just examples of some of our advocacy cases. Staff are overworked and underpaid, and in some cases, no staff exists. So under these circumstances, certainly harm is happening, and it will happen. In collaboration with Virginia Access, the ARC of Virginia's DD network is proposing to the General Assembly a DD system rescue plan. That is based on the recommendations from last year's waiver stakeholder group that you all pulled together, but with a more aggressive timeline and a focus on equity and sustainability. While this proposed package is for the upcoming biennium, it is part of a larger strategy to transform our system from being reactive in nature, only serving what someone's in urgent need, to proactive. To do this, first fund equitable and sustainable rates by funding services at the 75th percentile in the community, like what is included in the governor's budget for state facilities, including those services not included in the governor's budget that do help people to have a life like yours. Excuse me. Funding supported living, an alternative to group homes, equal to the smallest, most integrated group home rate, which is 4 persons, and that's the desired size for Department of Justice. Second, fund innovation to expand and transform capacity. Third, fully fund priority 1. And fourth, once the system stabilized, build core services for the over 10,000 people that would be left waiting before they're in crisis so that we can spend less on their needs. The funding investment we're advocating for is indeed significant. However, the cost of not funding the DD System Rescue Plan is much higher and much more detrimental for Virginians with developmental disabilities and their families. So thank you for your work, and thank you for your time.
Thank you, Tanya. Any questions for Tanya? There. Okay. Well,
All
thank you very much.
Yes, sir.
Karen, I believe you're up next.
Good afternoon.
Okay.
Good to see you. Well, Tanya kind of covered a lot of my points because we are working together on our joint rescue plan. So I thought I'd just take a couple minutes and thank you, first of all, for the 12.5% temporary rate increase this last year that goes through June 30th and ends June 30th, 2022. Quite frankly, I don't know what we would have done without it. We already had many of our day programs closed, our group support employment programs closed. And over the last 9 months or so, they've really tried hard to reopen, to convince people to come back, that it's safe to be engaged in programming again. Just to find out the other day on a call with members in Northern Virginia that a number of our large providers and providers in Northern Virginia have once again closed. They closed the week before Christmas, and they were going to reopen on the 10th of January and now have extended that again to the 17th of January. They felt it was prudent with the current variant going around to protect both staff and the individuals they serve. And because virtual services stopped August 29th for providers to be able to provide that delivery method, those people are home with their families or in their group homes or sponsored residential homes without day services. As Tanya said, the staffing crisis isn't new. And when Mike notified us on Saturday that to come testify today, I thought it would be interesting to go back and look to see what I said when we did the last rebase report in 2015 based on 13-14 data. And that was September 29th, 2015. At that time, we had a dire concern about the fact that the rate rebased based its assumptions, wage assumptions, on 50 percentile of the Bureau of Labor Statistics. We thought it was a flashing red light, especially for those high-cost areas like Northern Virginia and Richmond, that this would not solve our issue of expanding community capacity, because we cannot expand community capacity without staff. And staff, we ask a lot of our staff. They have to document, they have to have certain qualifications. They have to work with people with behavioral needs and significant health needs, and we need to pay them accordingly. Something I also wanted to point out so I'm not repetitive with Tanya, is that I think it's important to remember that DD waiver providers, unlike other Medicaid providers, rely solely on the DD waiver rate appropriated by the General Assembly. Unlike hospitals and possibly nursing homes, we do not privately bill. We do not. We don't privately bill. We don't bill Medicare. We don't have private insurance. We don't have private pay, et cetera, et cetera. So our staff wages are 100% solely based on the rate that we receive. So if the foundation of that rate is inadequate, the whole rate builds on something that isn't structurally sound. And what's funny is that's exactly what we said in 2015, that we needed to look at it again, maybe rebase every 2 to 3 years so we can keep abreast of what was going on, but we haven't. This is the first time since the last time we all got around the table and talked about this that we've rebased. I also included what happens, what the state of the community is because of low wages and how that affects staffing crisis. I included a graph that Tanya I put together that is based on data from DMAS that shows that pre-virtual services being available as a delivery mode of services to some folks, that services for group-supported employment and day services, which includes community engagement, community coaching, plummeted about 73.5% over the last 16 months. And it came up a little bit when virtual services were available to about 62% down. But then it's now going back down because virtual services haven't been available in that delivery for those services since August 29th. You've all heard it. You've seen it in the papers. The Washington Post is covering articles from New York. We are not unique with the crisis for the staffing, but I think we've almost could see it coming. And I think because of the additional resources in the budget, if we don't do it now, then when? When are we going to do it? When are we going to take care of this? Providers have closed, are closing, consolidating residences and programs. In many cases, a lot of my members who tried to provide community engagement, community coaching, and some of the other more integrated services are saying, oh no, we were losing money before COVID on these services because of the rates. There's no way we're going to take these on when we're able to reopen until we fix the rate service problem. Staff vacancy rates amongst our members have increased to a high of 38%. Overtime costs have exploded, of course, when you're short on staff. You call in your managers, your supervisors. That's exploded, and what happens is the human toll on those staff. They get burned out, and then they resign, and they just don't think it's worth it any longer. So what we ask of you, like Tanya said earlier, is that you please fund the full DD waiver rate rebase using a wage assumption at 75 percentile of the BLS. It's going to be a significant amount of money. But if not now, when? I also wanted to point out that you all know that the governor picked 8 of the almost 30 services under the waiver. You can't really pick and choose certain services. It's really a continuum of services. They're all and interrelated. You press on one, something else happens to the other. Individuals usually have multiple services. So if one provider can't provide services and another can, it completely destroys their individualized plan. And so we do not support this strategy of picking winners and losers. It's either all or nothing. And finally, I do want to say that, this is a people-person business. It's all about people. It's about our staff and the people they serve. And we want to make sure that we provide staff with a living wage so that, because of the backbone of our service system. Low wages undercut all of our efforts in increasing quality of services. And we need to make a significant investment in the system now that we have the resources. It tells a lot about us. If we don't do it now, then when? Thank you for your time.
Thank you, Carrie. All right. Jennifer Fedora. Yes. Got two Jennifers coming up. Jennifer Fedora will be first.
And thank you very much for being here and for listening, and I will try not to be repetitive of what either Tanya or Karen have said. Better? Okay, thank you. Yesterday, when I sat down to write my notes, before I did that, I went to get my lunch, went to Arby's. Big sign on the door. Dining room is closed because we have no staff. Yeah. You've seen those signs all over the place. When Arby's can't fill their vacant shifts, they bring in the managers, and I'm sure it is a manager who was at the drive-through window. If necessary, they scale back their services. Clearly, if we can't fill our shifts, we bring in our managers, we bring in our admin people. I was hearing stories about the bookkeeper who was working the night shift at a group home. And every other soul that we can find to cover those shifts. But we can't scale back services. It's just not doable. So the workforce crisis, as has been said, is, if nothing else, exhausting. It is wearing us out. You see the stories about the hospitals and the nurses in the hospitals and how tired they are. We're exhausted. We are absolutely done. And yes, errors occur. Things happen. I sympathize with the families who go and find someone not in the best condition. And that's terrible, and I'm sorry. But we're exhausted. So I have two thoughts. One, yes, please fund what the governor put in his budget. But recognize that those are only a small portion of the services. They are not the entirety, and they're not the ones that in a workforce crisis are going to be the most usable. The group day, the group supported employment, the larger group homes are the ones that are the services that we have. Admittedly, DOJ is not thrilled at this point, okay, but they're the ones with the staff to resident ratios that are maybe possible in a workforce crisis. You know, and they're good services. I mean, it's not that there's anything wrong with them, but they're possible until we get on the other side of this crisis. Without the funding, which you supply, you write those checks, and without that funding, we cannot raise the wages to be competitive. I just cringed when Commissioner Land said, you know, we want to pay $17 an hour. Oh. You know, any waiver service anywhere near a state hospital just lost their staff. Yeah, you know, $17 an hour in the state benefit package. We can't compete with that. So until we have something that can be truly competitive, we are not going to be able to get our feet under us enough to be able to deal with the priority one waiting list. You know, Tanya gave you the numbers. We can't grow. I mean, you fund slots, thank you, that's wonderful, great. But if we can't provide those services, the slots are meaningless. And we're just right there on the bitter edge of falling apart. So we have put in an amendment request. Thank you. Senator Hanger has, I think, agreed to submit it to do the rate increase for some of the other services that will at least utilize the rebase numbers that we have and will give us the opportunity to get rolling again a little bit. But this isn't the end. I mean, we're going to have to do this again. We have another minimum wage increase coming up in January of next year. You know, this may get us through this year, but it's not going to get us through forever. I want to say one other kind of thing that just I want you to hear it. I was asked to give a presentation at a House committee a couple of weeks ago. What were our session priorities? And it, I wasn't being facetious. I promise you I wasn't trying to be facetious. It was, we need stability. We truly need some stability in the system. Our system is not perfect. Our system doesn't do everything it's supposed to do. Our system doesn't work the way it's all entirely supposed to. But every time we perceive that the system is a little not right, we add a service. We change something. We tinker with something. We muck with this or we muck with this other thing. We are experts at standing up new services. We do that really well. What we don't know how to do is scale up a service to meet a broader need, because we rarely have a chance to do that. We stand up a new service, and then we stand up another new service. And we don't have the chance to give us 3 years, give us some time, give us something to be able to scale up what we've got. This is true of the Bravo services, it's true of the children's services, and it's certainly true in the DD world. We know how to do this. We just have to have a chance to do it and not be constantly in turmoil. So we need the stability in the service array. We certainly need the stability in the workforce. That's going to be the bottom line for all of this. And lastly, we need the stability and the sufficiency of the funding. If I could write the rules, which I can't, but if I could, I'd want you to be thinking at this biennium about what we're going to do for funding in the next biennium. Be thinking ahead enough that we're planning to do this thing so that we have some basis upon which to build a business and look ahead. Now, I have no illusions that that's going to happen, but I wish that's the way we were thinking about it. Even if you couldn't do it, you were thinking about it. So the workforce is our biggest issue. We thank you for the 12.5%, as Karen said. We couldn't have made it this far without it. We thank you for supporting what's in the governor's budget for the rebase. We particularly thank you if we can get the rest of those funding items in, and then think about what we're going to do next year. So, thank you for listening. Thank you for your time.
Well, thank you, Jennifer. Any questions at this moment? Okay, thank you, Jennifer. And finally, Jennifer from our Community Service Boards.
Hi, good afternoon. Jennifer Faison, Executive Director of the Virginia Association of Community Services Boards. Thank you all for inviting me to speak this afternoon. I recognize you are already about 7 minutes past your adjournment time, so I will try to bat clean up, as they say. I'm terrible at sports analogies, but I hope that's the right one. So, as you know, the Community Services Boards, are 40 of them, make up the public safety net. I look across this table and I see folks who have advocated on behalf of the entire system of care for people with behavioral health and developmental disability services needs. So none of you are strangers to what is happening in our system, and none of you are strangers to how critical it is to ensure that we're getting this right. So in what I would call a very rare change of events, for CSBs, we had a list of priorities that we had developed over the summer and into the early fall. And what we found was that there was a lot to like in the governor's budget in terms of matching up with the priorities that we had already identified. And so you saw both in Commissioner Land's comments and Director Kimsey's comments, a recap of what is included in those two areas of the budget. So I'll just very quickly touch on the things that we saw that we would like to protect and preserve, because we recognize that none of that is set in stone at this moment. Certainly the funding for STEP Virginia is critical. Funding those last three services will get us to that baseline level of services and supports that was the agreement between the state, the VACSB, DBHDS, and other agencies involved. At some point, we're going to need to go back and circle around to those very first services that we brought online, because that would have been in 2017, 2018, and recognize that we need to probably boost that funding level as well. But I'm not going to, borrow trouble. So just put that in the old back pocket. So we're very pleased to see the STEP Virginia funding in there. We're very pleased to see the funding for the waiver slots. We recognize that there are some challenges there in terms of getting those slots online and allowing them to be fully utilized. But what I will say is that it's an important statement of intent to include those slots in the budget. We do believe that things can get better with some of the other things that are in play right now in terms of funding. And so we would like the slots to exist, recognizing that we will be able to use them at a date certain in the future. We also were very glad to see what was included in terms of the waiver rate rebase. I think the comments of my colleagues really do track with what we see at the CSB level. It's incredibly difficult to hire and maintain staffing, especially when you've got these minimum wage increases coming online. And so we believe that what is in the governor's budget is an important step in the right direction. I will say, you paid for the rate study. You had a contractor that has some national chops. They did a thing, all of the numbers and the formulas that they came up with. I think you could battle on the methodology, you can battle on the numbers that they used and things like that. But the bottom line is they devised a plan for all of the services for all of the DD waiver services. And if you decide that you're going to do, let's say there are 30 and you're going to do even 28 of them, then those other two are just behind still. And then when you go to do the rebase the next time, you're going to have to bring those services you didn't do this time up to where they needed to be 2 years ago at the time of the 2 years in the future rebase, and you're going to have to start over with all the other services. So you're creating an imbalance that the rebase was in fact designed to even out, so that we're not just being like, oh, and you get like the Oprah special, and you get a rate increase, and you get a rate increase, without some sort of real balanced approach to how to do that. So we like what we saw, but we recognize that the whole methodology and the reasoning behind doing a rate rebase and the study and the modeling is that you have a comprehensive way to bring your system to where it needs to be. The other thing that was mentioned that we're really excited to see is the money for permanent supportive housing. That is not a service, quote unquote, that the CSBs provide, but what we know is that one of the biggest barriers to discharge for people who are clinically ready is that they don't have an appropriate housing placement. And it is very difficult to deliver services if somebody's living under an overpass. So when we can get somebody into a permanent supportive housing slot, it makes the effectiveness of those treatment and recovery services that much greater. So we're very pleased to see that funding in there. I think the last number that I saw was we needed in our system about 5,000 permanent supportive housing slots, according to a report that you all get each year, and we're at about 2,500 in Virginia. So we're making good headway, and I think Co-Chair Howell and many of you here on this committee have been committed to that, and it's incredibly valuable. So what is it that we didn't see in the governor's budget that's going to be really critically important for us? And that is that we did not see any direct funding to address the workforce issues within your CSB system. So what we know is that CSBs run 24/7 operations. Many of them run facilities. Okay. Many of them run facilities for individuals with developmental disabilities, which are intermediate care facilities, and these are people who also have complex medical needs. They run 24/7 residential group homes for individuals with DD, for individuals with substance use disorder, and we even have some behavioral health group homes that are burgeoning and developing. So same profile of individual, trying to serve those folks in the community. Many of the same staffing challenges that you have heard Commissioner Land speak about exist within the CSB system as well. And so what the VA CSB developed is a funding proposal that would be $167.5 million for a four-pronged approach to developing the workforce within the CSB system. And that would include recruitment and retention bonuses, such as a similar strategy as was provided to the state hospitals. I think Commissioner Land said very well, you know, it's not a silver bullet, if you will. It's a way to stabilize the workforce in order to, you know, so that you can get to where you need to be with it. So we would be looking at that. We would also be utilizing a portion of those funds to ensure that we could pay for clinical supervision for folks, growing them within our CSB system. You did see in the governor's budget $3 million that was appropriated for a contract with the Virginia Health Care Foundation. They do fabulous work. Our concern is that that level of funding and the parameters for the way that that program would likely be rolled out would not penetrate into the CSB system specifically, that it would be open to any provider, which is great. But in order to get that targeted penetration into the CSB system, we believe we would need funding specific for that purpose. In addition, out of those funds, we would be looking at funding some scholarships and loan repayment programs, recognizing that in some instances, a person has gone through a certain level of educational attainment and they need to be reimbursed for their student loans as a recruitment or retention tool. But on the front end, too, we recognize that there are people who cannot get to a new expanded level of educational attainment without some sort of financial support to do so. So that's really kind of the front end and the back end on a little bit more of a midterm way to help to grow our workforce. So that's basically in batting cleanup. What I would say we are looking at, again, want to emphasize the 12.5% rate increase that's been a savior in many service areas, especially because that was not relegated to what we would consider to be traditional HCBS services. There were some behavioral health services included in there as well. So we were very grateful for that and look forward to working with you all as this session moves forward on and the myriad, I'm sure, of legislative approaches as well as budgetary approaches to improving our public behavioral health system. Thank you all, and happy to answer your questions.
Okay. Are there questions? Well, I guess I would have just a couple comments. I noted just the recent passing of Mary Ann Bergeron. I guess she trained you? Or did y'all work together?
She changed my life.
Did she?
She absolutely did. Yep. She was a very special lady.
Yeah, yeah. you know, we've all been at this a while, and I guess we're in a transition point now with the administration where there are going to be a lot of new people involved that are going to have, I guess, a learning curve. But for some of us, myself certainly, because Senator Barker wasn't able to get a good agreement on redistricting, well, I guess we feel a sense of urgency because, I mean, the good Lord's in charge. We might not even be here tomorrow. But from a legislative standpoint, I'd like to see us get a lot done over the next 2 years. You know, I think that's really what our commitment needs to be within this subcommittee, particularly because, and the individuals here that have worked with us for years and hopefully will continue to work with us, I think we need a sense of urgency. We've had, I know some of you all, Allison, you in particular with behavioral health, and of course with the CSPs, all of us have been, you came on board and you had a learning curve, but you thought you were going to plow new ground. But with all the COVID, you've been going back and repairing the flood damage. So we're, hopefully, we can just basically commit to get this thing done to where we can, when we have the COVID behind us and the wind behind our back, that we'll come flying out the other end in a much better system here in the Commonwealth than we have currently. It's going to be tough, but I really sense that within the subcommittee, I think we have the commitment to get that done, and hopefully we can work on it, dig in, and get it done. Any of the other members have any comments or questions this time? Okay, well, went over a little bit. We got a lot of good information. Thank you, Jennifer, and all of you all. We will go ahead. We are live now, so I'm going to go ahead and officially adjourn this meeting of the Health and Human Resources Subcommittee, and thank everyone for your attendance present here and online. Thank you.